Hi, my name's Dave Zobek. I'm an educator, respiratory therapist, and a pulmonary function technician. In this interpretation of PFTs, hopefully you have watched Part 1, which covers the graphs and measurements. In this Part 2, I cover the shortcut on how to interpret these tests, these pulmonary function tests. And the shortcut version isn't perfect, but it sure will get you close to the accurate interpretation of this test. So let's move on and look at this information. That is lung mechanics. All of these measurements indicate or are measurements of flow. In the first section, we have the pre-bronchodilator, we have the actual and predicted, as well as the percent of predicted. Now, if we want to know if a bronchodilator is affecting or benefiting the patient, this is where we would look in the post-bronchodilator section. And we look at the percent change, and most of these we want to see a 15% improvement. The second section is lung volumes, and these measurements help us understand if the patient has a restrictive problem. And the key ones in here is going to be the FVC and the TLC. Now, if they're doing a body box measurement for total lung capacity or FRC, we're going to see it noted as TGV. So TLC and TGV are basically the same thing, total lung capacity. The last section is the lung diffusion. Of course, we just got done talking about that, indicating the change in the alveolar membrane. And then we also have the blood gases, which kind of go along with diffusion, but we want to look at the blood gases in relationship to the pulmonary function testing. Pulmonary functions. There are 8 key measurements that you should focus on. FEV1 second to FVC, total lung capacity, FEV1 second, FEF 25, 75, FEF 200 to 1200, DLCO, FRC, and residual volume RV. If you look at these 8 measurements and know what you're supposed to be looking at, your interpretation will be dead on. So let's take a look at the each of these measurements. When you look at a pulmonary function report, one of the first things you should do is look at the percent FEV to FVC. Now, this is extremely important because if it is less than 70%, then you can call this test, this spirometry, an obstructive disorder. Now, if you look at it and the FEV to FVC ratio is greater than 70, well, then you go and look at the TLC, and if it's not there, look for a TGV. Both of them are the same. If the TLC is less than 80%, you call this a restrictive disorder. And in many cases, you might not even find a TLC, so then look at the FVC. And if it's less than 80%, then it suggests restrictive disorder and a TLC needs to be done. Next, third one to look at is FVV1. If the pre-measurement is less than 80%, then you need to assess the bronchodilator, the response to the bronchodilator, and if it isn't there, then recommend that it should be done. Post-bronchodilation percent of change in FEV1 should be greater than 15%. If it is, it's called a significant response to bronchodilator. You can also say it indicates a reversible airway obstruction. The fourth measurement you want to look at is FEF 25 to 75%. Now, if the percent predicted is less than 80%, you can confidently say there's a small airways disease. But you're not done there. Look over at the post-bronchodilator and see if it's improved after the medication by 15% or greater. If it is, then you can say it's a reversible small airways disease. Now, terminology that we usually use with the bronchodilator response is a significant improvement after bronchodilator. Anything 15% or greater is considered a significant improvement. Next, we're going to look at the FEF 200 to 1200. Actually, this measurement is the air coming a little bit before that FEF 2575. But if the FEF 200 to 1200 is less than 80% predicted, then you can say the patient has a large airway disease or obstruction. The sixth measurement you're going to look at is DLCO, and if you have a greater than 80%, then there's no problem with diffusion. If it's less than 80%, then you have a thickened alveolar capillary membrane, or you have a condition that causes diffusion impairment. Seventh, you want to look at the FRC. And here, instead of less than, these are going to be greater than. If you have a measurement that shows greater than 120% of predicted, then that means the FRC is excessively large, and we call that hyperinflation. Now, you check the RV. If that's greater than 120%, that indicates air trapping, meaning you have a larger than normal trapped amount of air that you cannot exhale out. Now, part of pulmonary function testing is determining the severity of the abnormality, severity of those of obstruction, of restriction. So we look at these measurements as we're doing them. If they're greater than 80%, then we have a normal condition, a normal measurement. If it's 65 to 79%, it's classified as a mild condition. 50 to 64% is a moderate condition. 35 to 49% is considered a severe impairment, severe condition, and less than 35% is considered to be classified as a very severe impairment. So an example would be if you had an FEV to FVC ratio of 63% of predicted normal, that would be stated as a moderate obstructive condition or disease. The FEV1 pre and post change, if it's 17%, let's say, then that's a significant response to bronchodilator. So let's interpret a pulmonary function. This is a graph of the pulmonary function that we're going to be seeing, going to be evaluating. What does this loop look like? If you think back to the images of those red loops, this is gives you the feeling that you're probably going to see a restrictive problem in the data. Now, you cannot make an interpretation by the shape of the loop, but it sure gets you thinking, is that a restrictive problem? Now, we're just going to grab a bunch of little measurements here instead of having a printed pulmonary function report. But here you can see FEV, FVC, FEV1, FEV1 to FVC ratio, peak flow, and FEF 2575. And we have the measured amount, the predicted amount, and the percent of predicted. So take a little look at this and start thinking, okay, what is abnormal and what is normal? Remember, most of these are going to be less than 80% is abnormal, with the exception of that FEV1 to FVC. That has to be less than 70%. Now, okay, so we have the FVC. Is that a normal amount? No, it's 35% of predicted. So in this case, it's going to be a restrictive condition, but as we said, you cannot use FVC as a final interpretation of restriction. Now, regarding the FVC, the percent predicted is severely low. It indicates possible restriction. We cannot be confident that this is a restrictive disorder until we see a TLC that shows us the total lung capacity is reduced. Now, the 35% predicted is severely low. If it was at 34% predicted, then it would be very seriously low. Now take a look at the FEV1 before we move on. Now the FEV1 second at 49% of predicted is also considered to be severely low. Again, this may be due to the fact that there is a restriction potential causing the lungs to be not fully inflated, and when that happens, your FEV1 may also go down. Now take a look at the FEV1 to FVC ratio. Now the FEV1 to FVC ratio, those measurements are already a percentage. So we don't look at the predicted other than just to know what it should be. And we don't look at the percent predicted. We simply look at the measured amount, which is 98%. So that is well within the normal range. Thus, it does not indicate any obstruction condition of the lungs. Take a look at FEF 2575. Now the FEF 2575, we're going to go back and look at that column for percent predicted. That's reading at 107%. So that's well above 80%. Thus, there's a normal condition, and it does not show any small airways obstruction. Now, the last one is to look at peak flow, the PEF. The PEF is low, moderately low. This may be due to the fact that there probably is a restrictive lung disease, lung disorder. And when that happens, you don't get to fill your lungs as fully as necessary, so you don't have enough to blow out fast and quickly, and thus it makes your peak flow a little bit lower. For this section on pulmonary mechanics, all of these flow measurements are what we're assessing. The FVC is severely low, which indicates possible restriction. We need to confirm that with a TLC. FEV1 is severely low, but that may be caused by the restrictive condition. FEV1 to FVC ratio and FEF 25-75% are normal, thus no obstruction indicated. A moderately low peak expiratory flow rate may also be due to the suspected restriction. Now here's the second spirometry that we're going to take a look at. Look at the loop. What does that tell you? Think back to those various loops we had in red. Again, we get an idea that this looks fairly normal. It would appear. The shape isn't so bad. We just don't know for sure how that's going to work out as far as the normal values. Here is an overview of the next pulmonary function report. And if you take a look at the pulmonary mechanics, we have FVC down through peak flow, and we have both pre-bronchodilator and post-bronchodilator information. We also have the DLCO, diffusion capacity. We have FRC and RV, as well as the TLC. So we got a lot of information. Most all of this is going to be necessary to create our final interpretation. Let's focus first on the pulmonary mechanics, all of those flow measurements. And the first one we're going to look at is going to be the forced vital capacity. Now, what you know about forced vital capacity, what you've learned about percent predicted, make your estimates of what this is telling us. That really wasn't so hard. Forced vital capacity at 84% of predicted, that's within the normal range. And so this does not indicate any restriction, not by the FVC at least. So let's look at the FEV1. Take a few seconds, pause the video if you need to, but look at what that's telling us. The FEV1 second is mildly reduced. 70% is what we like to see. It's at 69%. Again, we would want to look at a post-bronchodilator to see if there's any change. And we'll get to the post measurements in just a little bit. So at 69%, that's a mild decrease in the FEV1. Take a look now at the FEV1 to FVC ratio. So the FEV1 to FVC ratio is 60%. That causes it to fall right in the moderate obstructive condition. Not much more we can say about that. Let's move to the FEF 25-75%. Now, think back to where this is measuring as far as the lungs go. What air is it measuring? Large airways, small airways, what? The FEF 25-75 is way down in the percent predicted, 23%. That puts it at very severely decreased, indicating small airway obstruction. So we have a moderate obstruction by FEV1, FVC, and we have a very severely decreased FEV1, FEF2575. Now, you can look at the peak expiratory flow rate. It's 85%, so I just put it down there. No guessing about it. It's a normal peak flow. Now, if all we had was the pulmonary mechanics to evaluate the patient, maybe this is a bedside spirometry or something on that order, and all we had to do was this information, the interpretation would read such as this: normal FVC, no indication of restriction. FEV1, mildly decreased, post-bronchodilator evaluation may be indicated. A moderate obstruction noted with FEV1 second to FVC, and FEV 2575 is very severely decreased, indicating small airways obstruction, a normal peak expiratory flow rate. I prefer to go and look at the post-bronchodilator information or data after I've looked at the pre-bronchodilator. This helps me kind of look at what's happening in the patient, and so we're going to look at the each one of these measurements, and the question is, do we need to really look at all of these? Actually, we don't need to look at all of these. The two key elements are the FEV1 second and FEF 2575%. And so we see there's some changes there, and I want you to start thinking, is there any significance to giving this patient bronchodilators? We might be doing the post-bronchodilator test to help a physician know whether or not sending a patient home on a bronchodilator, even an MDI, is going to be beneficial. So after the test, we look at the FEV1 second, and we say there's a 17% improvement in the FEV1 second, which is a significant response to bronchodilator. Now, the FEF 2575 is also significantly, very significantly improved. This is the measure of the small airways disorder, and both of these indicate that bronchodilators can be beneficial in this patient. So let's now move to the last section, which includes the diffusion, lung volume measurements. And so the first one we're going to look at is diffusion. Is the 46% of predicted in the DLCO a significant indicator of a diffusion problem or not? Of course, the DLCO at 46% of normal is low. The diffusion capacity would be rated as a severely reduced. And so anything with diffusion capacity of less than 80% indicates an abnormal condition. Now, let's go on to look at the FRC and RV. We'll do these together. And so this is going to be something you have to think back to what I said earlier about these two measurements. And then we'll go on and tell you what they are telling us. Now, the FRC and RV are not considered abnormal if they're less than 80%. They are considered to be abnormal if they are greater than 120%. So anything greater than that means we got excessive volume in the lungs. So with the FRC being at 122%, this would be an indication of hyperinflation of the lungs. The lungs are overly filled with air. And so in that case, it's going to be taking away airspace from the inspiratory capacity. Now, RV is 121%. Of course, both of these are just over the line, but RV at 121%, it shows that there's the presence of air trapping. Remember, residual volume is that amount of air in the lungs that we cannot get rid of. And so if residual volume is increased, that is air that's trapped in the lungs. And so that's why we classify it as air trapping, and the other one as hyperinflation. Now take a look at the TLC, and what does that tell us? The primary value in the TLC, as far as the way I'm looking at it, is it indicates restrictive condition. Volume measurements indicate restrictive issues. So here we have a TLC of 110%, means the patient has got slightly larger lung capacity, and that's not unexpected because RV and FRC are both increased. So the TLC being increased is classified as no evidence of restriction. Now, if the TLC was less than 80%, then you would have a restrictive lung condition. Let's look at the whole pulmonary function report. This is all the data that we just got done looking at. It's been thinned out so that there's not so much that makes it easier for me to talk about this. So we see that from FVC down to peak flow, PEF, that's the pulmonary mechanics. We have both pre-bronchodilator and post-bronchodilator. Following that is the diffusion capacity, and then we have the FRC, RV, and TLC. So within this whole bit of information, we really are looking at 8 measurements, 8 pulmonary function measurements that are helping us determine what the patient's pulmonary function is telling us. What is the interpretation of that lung test? So a pulmonary function interpretation report probably would look something like this. PFTs show an obstructive disorder with very severe small airways disease. There is significant response to bronchodilators. Diffusion capacity is severely reduced. Hyperinflation and airway trapping is noted by increased FRC and RV. So there are 8 key measurements that you should look at. If you can remember these 8 key measurements and what you're looking for, then you should be able to get a pulmonary function interpretation that is almost as good as the pulmonologist. So we have the first one, FEV1 second to FVC. Remember, that one is 70%. If it's less than 70%, you have an obstructive problem. If it's greater than 70%, then you should check the TLC to see if there is a restrictive problem. Then we have the FEV1 second and FEF 2575 and the FEF 200 to 1200. Those 3 measurements are going to indicate to us various levels of obstructive condition, and that they will also be affected by any change with bronchodilators. Then we have the DLCO, which is 80% or less, indicates an abnormality. And then we also have the FRC and RV, and both of those have to be greater than 120%. FRC is hyperinflation of the lungs. RV is air trapping. Well, that does it for interpreting pulmonary function reports. I hope this has been helpful. Pulmonary functions are a lot of data. They scare a lot of people, but if you focus on the 8 key measurements, then you will be able to do very well at identifying what the patient's condition is. Hope that was helpful to you, and I'll try and do some other educational pulmonary respiratory presentations. Thank you very much.